Everyone ages. Sometimes we have to go into the hospital for care. The older we are, the more stressful the hospital experience might be on us. If an older loved one has dementia, the hospital experience could be especially stressful. More stress means there's a greater chance that a loved one's baseline health can permanently change for the worse. But if families partner with healthcare providers, it means more individualized, patient-centered care. Together, families and healthcare providers can provide better hospital care for an older loved one.
One of the highest risk factors for developing dementia and cognitive problems is age. So as people age, as people live longer, there will be more and more people in hospital settings who have a cognitive problem.
I think we do a good job managing a person's acute illness, figuring out just the right antibiotic for the pneumonia, but the dementia piece underneath just is, it's not assessed for. And if we're not assessing for it, and if we're not talking with family members, then we don't really know what we're dealing with.
And we need to partner with families who provide an incredible amount of care and supervision and structure to these people at home, and have an incredible amount of information to share with us so that we can try and better meet that person's needs.
And our goal is to let people know that that's just as important as all the high-tech procedures that the hospital has to offer, that we really want to have those conversations and partner with our families to get this information about patients so that we can make this hospital stay a much smoother process.
The other part of this then is education amongst our own trainees, understanding dementia and understanding aging. Is something that we're not taught in nursing school and physicians aren't taught necessarily. So really stepping back and sort of being specific about what that means.
Any hospitalization is stressful for the average person, for you and I. When you have a patient with dementia, I think the stress level gets even higher because they're dealing with many of them are dealing with cognitive impairments that can make the hospital a very scary place.
The hospital environment is really designed and meant for those of us who work in the hospital. So, for example, things can be very noisy because we need to talk with each other. We use intercoms. We're filled with equipment and things that are not easily understood, even by someone who doesn't have dementia. But when you add the dementia component on, it can be very stressful and very frightening.
Which is why we really ask families to be involved during the hospitalization and from the beginning, because oftentimes it's families who we're relying on to tell us as much as they can about their family member with dementia, because our goal is to make it as comfortable as possible so that we can treat the patient effectively.
Well, dementia, strictly defined, is a deficit in somebody's cognitive function, and often it affects their behavior and their personality. And if you rule out all the treatable causes, you're left with this condition that's called dementia.
There's a lot of different types of dementia. The most common type we think of is Alzheimer's disease. It is important to know what type of dementia a person has because each one of the different types of dementias has a different cause and a different trajectory, and so planning is really important for the patient and for the families.
You have this cognitive problem, and it's in sufficient degree that it's affected your ability to carry on your independent function, and you require other people to help you with that. And in this country, as in most, we rely on family caregivers to provide that assistance.
I married my husband, Sam, in 1959. He was a physician and ophthalmologist, eye doctor. He liked to hike and walk. He always has read a lot, and he was very up on things all over the world, really. I didn't give aging much thought. It was just something that was going to happen. And I think as long as I was feeling good, I didn't have to think about it. One of the first things I noticed was one day when he was trying to park the car, and he had just lost track of space. He kept turning the wheel in the wrong direction, and the car kept not going, and he kept at it, and was very annoyed when I said, I think you should try to turn the wheel the other way. He just couldn't see it.
Well, I think one of the hard things is that the person's still there, but then all of them isn't still there. So on the one hand, you're fortunate, there he is, but you can't have the same discussions or do the same things.
It's sort of like having a child again, in a way, where you do become responsible for all sorts of things and making them go right.
Delirium is an acute change in mental status that is about 5 times more common occurring in people that have dementia. You put a person in the hospital that already has that going on, and let's say they have an infection, let's say they have pneumonia, and then we put them in a room that they don't recognize, and we don't keep them from becoming dehydrated, and they get an acute mental status change on top of their chronic change. So we may refer to that as delirium superimposed on dementia.
Like delirium really poses huge risks and problems. So in the first place, we increasingly know that people who have delirium don't usually get back to where they were before. So maybe they have to go to a nursing home, maybe they never walk as well, maybe they never think as well. Maybe they then lose their independence, which is the most precious prized thing any of us has. So it's not just, this inconvenience of confusion and it's a little harder on everyone. It's really a huge risk for lots of other bad things. And what started that was in part age, but in big part the dementia that really puts people at huge risk for delirium.
Leave me alone. Keep your hands off. Sir!
There are 2 kinds of delirium, and there's one kind that's much more visible, and that's when the person's all agitated and yelling and trying to get out of bed and hallucinating. And that one people rarely miss. So the second type of delirium is actually maybe more worrisome, and that's when the person just gets really quiet and doesn't say or do much. So if an older person is really quiet and sleeping a lot, and doesn't seem to be a person of many words, it's absolutely critical that the people taking care of him or her find someone who can say, is this always a really quiet person that doesn't say much? Because usually the answer is no, and then that means they're delirious, and you need to start figuring out what's going on and trying to treat the contributors so you can make that person better.
I always felt tender, even towards myself, with the Alzheimer's, because it had been my grandmother and then me.
It took us about 2 years to finally get her to see the doctor. But even during that time, it never occurred to me that it was Alzheimer's. When I heard, it wasn't something that really set me back. It hadn't set in yet. because I didn't know that much about Alzheimer's, and so it's just something that now it's part of our lives.
Also, I mean, Wayne and I have known each other since high school, so that kind of makes a big difference. And I knew Wayne would be there for me no matter what, and he would be the same, I think. I would do the same for him.
When someone is sick and acutely ill in the hospital, it's not really a good time to try and determine do they have dementia or what's going on, because their acute illness may cloud how they really would do at kind of their normal baseline. So often the first time we see a problem is when they're in the hospital, and we start the conversation with the patient and the family member about what this could mean.
When you came in, you were asked some questions.
And it often, unfortunately, means that they do have dementia, and it's not been identified yet. It's not been worked up. And often the hospital stay will unmask these problems that have been going on for a while.
And when you talk with family members to say, have you noticed this? There's something that arises to say it has been a progressive nature, but something for them even they had not noticed until it really does hit them when they're in the hospital, where there's time spent with this patient really one-on-one. So then you have to deal with two things. One is the guilt of the family to say, oh my gosh, I did not realize that this was occurring. And also then now what do you do in terms of the patient who may have come in for a broken hip, who actually then is moving on, but now they have this other impairment of which we then feel obligated and right to do so to think about. I think the first part of this is to make sure that we spend time with the family. Many years ago, nurses had time to actually have family conferences and to sit and talk and really listen to patients' families and the patients themselves. I think there's less time, so it has to be more efficient and more effective. But I think you still can do it. I always, argue that when nurses go into a room, while you're in the room, have those conversations and dialogue, but really listen. And I think it's that skill set that we have to bring forward again, and being able to understand how to multitask, but really paying attention and listening as well.
We do a wonderful job with all of our technology and taking care of people and helping them to recover. But again, it's a system that's designed to sort of meet the average person's needs. And these people really need someone to slow down and take time. They're misinterpreting probably a lot of the directions and stimuli that they're getting. And because they don't necessarily have the language ability and the cognitive ability to respond the way they used to and say, please, could you go slower, or I don't understand what you're saying, often their response is to push back and resist care or resist something that they're being asked to do. And a common example is, telling a patient to be sure and use the call bell to get out of bed to go to the bathroom.
Good afternoon, sir. How are you today?
Trying to get staff to understand that the patient, even if they returned that demonstration, even if they looked like they understood how to use the call bell, even if they nodded and said, yes, I will, that when you left the room, they probably totally forgot that conversation. So I think it's very common that we don't understand the level of limitation that people with dementia have and structure our setting and our conversation to that level.
So I went out and contacted them and made sure that they understood that she had Alzheimer's, and they said, yes, they understood that and so forth. And so then that was fine. And then very soon thereafter, they came in and they started explaining to her the handheld remote. Now this is your TV, and this is how you do this, and then this controls your up and down bed. And I'm saying, my eyes are rolling, and I says, no way. I says, let's concentrate on the red dot, which calls the nurse. And so that was of a concern to me, that they were wasting their time is what they were doing, and they knew that if an Alzheimer's patient just doesn't respond to that thing in that kind of a situation.
The last couple of times my father's gone into the hospital, we've told them that he tends to get confused and get up. And on each of the different units, they've had these pressure pads that they put under the mattress where he lies down. And if he gets up, it makes a sound. And they didn't used to have those. And we had asked several years ago, and they didn't. And now on different units, we just mentioned that he's confused. And right away, without blinking an eye, they'll move him closer to the nursing station or in a room where there's already somebody watching someone else. I think we're starting to make progress.
I was off at a meeting and I got a 911 page to come up to the floor. And what had happened was this woman started to become a little bit agitated. So she started looking around her room and no longer recognizing anything in the room. And so she was going from room to room looking in the rooms. And so when I got to the unit, she was kicking the door of the room to get in and was screaming. And so as I was walking down the hall, I was thinking, oh my goodness, what am I going to do? And I went up to her and I said, Mary, how are you? And she stopped kicking and just turned to look at me. And I said, I'm making some tea. How about having a cup of tea with me? And I could see in her brain and in her eyes that it just completely broke that thought process of trying to find her bedroom. And she said, well, okay, that sounds good. And that's how we got her back in the room. So if you understand what's going on and try some tactics that you kind of learn, getting someone's attention away from what they're trying to do and focused on something you want them to do is often really helpful. Even with dementia, people need to have a purpose. So I sat with this woman, we had tea, and what I said to her was, I need some new pictures for my office. How about if we sit? I've got some paints. And so she was perfectly happy to sit and paint. We always need to keep in mind who these people are and the fact that they do need to accomplish something.
There are units that really sort of focus on taking this really vulnerable, frail population and trying to, as much as possible, protect them from sort of the routine hospital environment. So getting people up, getting them mobile, making sure they're eating and drinking, making sure that they're engaged during the day and that they're sleeping at night, and as much as possible following their routine really has been shown to, in a very cost-effective way, to reduce people's lengths of stay and to reduce their functional impairment when they leave. So there is evidence that really intervening and trying to get people mobile and maintaining their functional status as close to it was before hospitalization can really have good impact on outcomes.
Many hospitals have developed these special units, and hopefully more will. But it would also be wonderful if some of the things that are in the units could just be brought to the patients who need them.
Families, I would say, are equally as important to the hospital stay as any of us are as providers. And they have such a fantastic degree of knowledge about the person's routines and how to soothe them, for example.
Our doctor wanted to do a biopsy, and so I went into the hospital. And you're thinking of biopsy, some little teeny tiny thing like that. And what was it, 4 days later? Yeah, about 4 days later before I got out. We think that we should have been prepped for that a little better.
And I hadn't prepared to spend the night, and I really needed to. And I was kind of torn by that, but I had to get back. And we were 45 miles away from our home where she was in the hospital. And so that was, took some doing to get there. So the next day when I came back, I brought my stuff, and I planned to spend the night from that point on.
Well, it was really nice when I saw Wayne walk in the door, and I was so happy and comfortable to know that he would be there and we could have a conversation and he could tell me what he'd been doing and I could ask him some questions.
My job as her caregiver with her Alzheimer's is to kind of buffer situations that cause stress and anxiety and foremost traumatic experiences, because stress and anxiety really causes her disease to progress faster than I think it should. And so if we can stop that anyway, then it's better.
I think there are some ways to prepare. So if you know that you're bringing your loved one with dementia into the hospital, making sure that you come with a list of things. So, for example, a list of current medications, including over-the-counter and the dosages. Having a familiar object. So it might be a religious icon like a rosary or a statue. Sometimes I've asked family members to bring those things in. A CD, a DVD player, and headset so a person can have their specific music. Pictures, a blanket or a comforter or a robe. Things that are familiar to the patient to help soothe anxiety and ease them a bit. Other things that are really important are to make sure that the person has their glasses and hearing aid. Very important to help prevent someone from becoming delirious in the hospital.
One of the key things that's helpful for us to know would be exactly what the person is capable of doing at home and what works at home.
To try walking a little bit?
So, for example, do they bathe themselves at home or do they get help? Do they dress themselves at home or do they get help? Some of the real basic things that we want to continue to try and do according to their routine at home so that it's not disruptive and so that they continue to do it when they go home.
If there's a favorite nickname, if there's favorite rituals around meal times, around bedtime, we'd really like to know that we think that's really important and vital information that they know about the person.
What strategies work for medications? Some people don't do well taking their medications. Is there a particular juice that works? So, we don't have to spend 5 days trying to figure out how to give someone a medication when their family intuitively and based on a lot of experience and care know the best way to take care of this person.
A lot of the routines we may not be able to follow exactly, but I think the goal is to try to follow them as closely as we possibly can. I know I've worked with families that if their loved one does require hospitalization, sometimes the families who have been providing all of this care 24/7 at home look at the hospitalization as a chance for them to have some respite. And then on the other side, we have the hospital staff, the nursing staff, the physician staff that say, well, wow, we really actually need you very involved at this point. We need you here present with the patient to help keep things safe, and we need information from you that will help us plan their care. So I think sometimes that can be a challenge of trying to respect the fact that they do need a break, but the hospitalization may not be the perfect time for them to take that break. And really, the respite or the break might need to come as part of the discharge plan.
When I have a patient with dementia admitted to the hospital, the first thing I do is sit down with the family and make sure they understand that we are planning the patient's discharge from day one, because I want the family to be prepared and not anxious about what's to come. And I also want them to know that in this healthcare environment, hospital stays are generally very short. So families often tell me that they find that we're springing a discharge on them when they're absolutely unprepared for it. So my goal from day one is to sit down with family members and begin talking to them about what will the next step be.
The hospitalization is a time to maybe think about what services or resources they haven't availed themselves to.
How much motion do you have in that ankle, Nan?
And there may be resources like physical therapy or some counseling with the pharmacist on medications, and those are all things that the family could be thinking about that they, could maybe need, and we could try to set up for them, either during the hospitalization or for afterwards.
I'm your mom's nurse today.
I think being able to explain to a family member, keeping that person out of bed, sleeping, hydrated, with their glasses and hearing aids. Those are the things that will optimize their discharge plan. And getting them to partner with us is really important because often the family can cue a person much easier than a total stranger can. So having the family really active in that is important. And then if there is no family, then really from a nursing perspective, it's up to us to identify that and put that into our care plan.
This sort of care is very burdensome, very time-consuming, and so families often need help. And that would be another example of where we'd like to partner with them. Our nurses and our social workers might be able to make suggestions about that discharge process and how to get more help in the home for the family member.
One of the real benefits that we've encountered since she's been diagnosed is we got involved through our Alzheimer's Association with a support group for early onset cases. And so every Thursday she goes to her group and I go to mine at the same time, but we're not the same groups, of course. And that has just been so helpful to me and also to her own session.
Well, about a little over a year ago, we moved into a senior retirement place. And that's been fabulous because he was basically sitting at home, reading, very slowly, of course, and making no plans for himself ever. Now he's got all these people around and their activities, many of which he enjoys, and it's really been good. He's very, very happy there. So life is in some ways gotten easier. In other ways it's harder, but that was a very good move.
Actually, the Alzheimer's has got some good news and some bad news. Bad news is it's a horrible disease. The good news is that I think it's brought us closer together because I don't have any problem taking care of her. I mean, she did it me for over 40 years or so, and no problems. And I said, there's no reason why I can't step in and do my part now for her, and that's exactly what I intend to do.
Going forward, I think that I would really like to see an acknowledgement of the specialized care that these patients require.
What do you think about our view?
It really is a very highly skilled intervention, working with these patients, being able to structure their setting, being able to interact with them, and being able to meet their needs in sort of a caring way that allows them to navigate a hospital experience or a difficult illness or a surgery with the least impact on them at discharge. And developing that and nurturing that among the health providers, I think, is really key going forward.
So we're really hoping to partner even more so with the family member who knows so much information about that patient, partner with them so we can anticipate and plan their care around those individual pieces of information.